speakers, facilitators, and have questions. There may be an opportunity to actually have an interaction as these presentations are going on. And I think that is the most important thing, is for us to share these experiences. Having said that, then let me move to the first presentation that we're going to have. I would like to just make a quick highlight, and I'll ask the colleagues, as you present, please just give us a very short, a brief intro of who you are, what institution you are affiliated with, and what could be your research interest or interest in NCDs and COVID. I think if we get those three at the beginning as you introduce yourself, we'll get a good feel of who these eminent speakers are this afternoon. I would like to then invite our first speaker, that's Dr. Grant Mareva Nema from the University of Zimbabwe. And he will give us the key highlights of what the problem is, or what the situation is to date with regards to COVID-19 and non-communicable diseases in the Africa region. Dr. Mareva Nema, are you ready?
Yes, Professor, thank you. Let me share my screen.
You have about 10 minutes or so to do this, so we can, or less. And colleagues, feel free to raise questions in the chat box.
Right, good afternoon to the President. Good afternoon to everybody who's in this webinar this afternoon, colleagues. Thank you, Professor Munodawafa, for inviting me to give an overview in terms of the epidemiology of COVID-19 and NCDs in Africa, which I believe is important and is going to form a great foundation for the talk this afternoon. Now, my talk is quite a brief summary, because these are issues that we've been talking about daily. About myself, I'm a public health physician and an epidemiologist in Zimbabwe. I'm also an obstetrician and gynecologist working primarily as a senior registrar in the Department of Obstetrics and Gynecology in the Faculty of Medicine and Health Sciences at the University of Zimbabwe. I have wide-ranging research interests in infectious diseases and non-communicable diseases, and with a particular focus on diseases of the reproductive tract. And I've been very actively involved in the COVID-19 responses in Zimbabwe. So this is what I'm just going to briefly highlight in the following few minutes: the global epidemiology of COVID-19, the epidemiology of COVID-19 in Africa, the epidemiology of NCDs in Africa, and then COVID-19 and NCDs. What is the intersection, which is why we are here today. So this is basically an epicurve that we are all familiar with, which shows us what's been happening from the time when the first cases of COVID-19 were detected, when it was declared a global pandemic, and the three waves that we've had. As we can see, we have the Americas and Southeast Asia's currently is reporting the highest number of cases. But of course, Europe has also been badly affected, particularly in the second wave. It's much less affected currently. And as you can see, the African continent is the fifth most affected continent. So in the first and second waves, the burden of COVID-19 in Africa was actually quite low as compared to the rest of the world. The key highlights: 3.8 million incident cases were actually reported in 7 days between 19 and 25 July 2021, which represents an 8% increase in the case burden as compared to the previous week before that. The average number of incident cases per day, that's globally, was 540,000 compared to 490,000 that had been reported the previous week. And what we note are substantial increases in the Americas and the Western Pacific regions. 69,000 new deaths were reported in those 7 days, which represented quite a sharp 21% increase compared to the previous week. Again, with the Americas and Southeast Asia also contributing the most. In terms of the cumulative number of cases of COVID-19 to date, about 194 million have been reported globally, and it is projected that in the next few days we'll probably have reached 200 million cases, and the cumulative number of deaths from COVID-19 are now in excess of 4 million. So this is just an indication of the global statistics, just highlighting what I was just talking about. And as you can see, Africa reported 184,361 cases in the preceding 7 days. I'm going to come to that. Now, in terms of the epidemiology of COVID-19 in Africa, this is a graph from the WHO Afro region. The 3 distinct waves that have occurred so far are actually quite clear in this epicurve. And as you can see, the waves have actually been progressively getting more serious, with the 3rd wave having reached a peak as far as we think. The key highlights include the fact that 169,000 incident cases were reported from 19 to 25 July 2021. But for Africa, unlike the rest of the world, these actually represent a 15% decrease in the number of new cases compared to the previous week. As I have just highlighted, the 3rd wave has started trending downwards. However, the incident cases remain high in Africa, with a daily average of over 20,000 cases per day. Now, when you look at Africa as a whole, South Africa is contributing by far the greatest burden of the cases, and it's reporting about 49.8 to 50% of the cases. However, Zimbabwe, which is where I am from and where Prof Munodawafa is from, is actually kind of the 2nd highest at the moment, contributing about 8.4% to the new cases that were reported in the previous week. But of course, Mozambique, Algeria, and Zambia are also contributing substantially to the number of cases. The weekly fatalities, however, are rising, and they actually rose by 3.4% in the same period, with 4,917 deaths that were reported from 35 countries. The case fatality rate on average remains about 2.4 to 3%, but of course some countries such as Zimbabwe have high case fatality rates that are almost reaching 4%. South Africa is contributing close to 60% of the fatalities in the African region, followed sadly by Zimbabwe, Namibia, Zambia, and Mozambique. And what's good, however, is the number of African countries have rolled vaccination programs. The numbers of the vaccinated are still insignificant, but we appreciate the efforts, especially considering that most of the African countries were not part of the COVAX agreement. And when you talk about Zimbabwe, it has actually made quite significant strides towards this vaccination. And since rollout, we have actually vaccinated in terms of the first dose, over 1.6 million individuals, and about 700,000 or so, representing just less than 5% of the population, are actually fully vaccinated. But of course, considering the challenges in terms of acquiring the vaccines, the politics, the nationalization of the vaccines, and so on, I think we are doing quite well. So now, just coming briefly to the issue of the NCDs in Africa, which is the reason why we're here. The burden of disease in Africa previously, if you go back to the past 2 decades or so, was previously dominated by infectious diseases. We know what HIV, TB, malaria, and a range of other infectious diseases actually did to the African region in terms of mortality. However, as you know, we have been undergoing an epidemiological transition and we have changing population characteristics. Therefore, the risks for non-communicable diseases have been increasing, accompanying the lifestyle changes that have also been happening in Africa with changes in diet, an increase in obesity, smoking, alcohol consumption, and all those. We know they have been contributing to the change in the epidemiology of the non-communicable diseases. And the results from the Global Burden of Disease Study 2017, which were published last year, show that there is quite a marked need to increase the attention to non-communicable diseases in Africa. This is just an abstract of that Global Burden of Diseases study, which was published in Lancet Global Health. And basically, it's just showing in terms of the WHO Afro regions, the burden of the different types of non-communicable diseases among males and females. And as we can see, they are now quite important across all the regions with cardiovascular diseases, diabetes and kidney disease, musculoskeletal disease, respiratory diseases, and cancers actually contributing quite substantially. So non-communicable diseases represent the leading cause of death worldwide. When you look at the global burden worldwide, killing about 41 million people annually, which represents about 71% of all the deaths globally. And the four top killers accounting for 80% or more of all the premature NCD deaths globally are cardiovascular diseases, which kill an estimated 17.9 million people annually. Cancers, these are different kinds of cancers in different locations, accounting for over 9 million deaths annually, and then followed by respiratory diseases and diabetes mellitus. So these four are quite important and of major public health significance because of their contribution, not just to mortality, but also to morbidity, to health expenditure, to the burden on the fiscus, the health budgets, and so on globally. And in sub-Saharan Africa, there has been a surge in the non-communicable diseases, like I said, over the past 2 decades, and chiefly driven by an increase in the incidence of cardiovascular risk factors, which include unhealthy diets, sedentary lifestyles, hypertension, obesity, diabetes, dyslipidemia, and air pollution, and of course, an increase in alcohol consumption, an increase in smoking, all of which are contributing quite a lot. And it has been projected that non-communicable diseases may actually overtake the communicable, maternal, neonatal, and nutritional diseases combined to become the leading cause of mortality in sub-Saharan Africa by 2030. And so important interventions are required to curb the increasing burden of non-communicable diseases in sub-Saharan Africa. And the important starting point, at least for me as an epidemiologist, would be the provision of reliable epidemiological estimates of non-communicable diseases. And as you can imagine, most of the data is usually actually incomplete. Notification is incomplete, surveillance for non-communicable diseases is incomplete, and there's a lot of missing data. So we might actually be significantly underestimating the burden of non-communicable diseases. So in order to appropriately inform prevention and control strategies, we need to improve in terms of the epidemiological estimates. So what is the intersection between non-communicable diseases and COVID-19? This is something that we are probably all familiar with, that people, and this is evidence that also came from a systematic literature review, though there was no meta-analysis for this, but basically results from these reviews tend to corroborate results from studies and results from surveillance that people with certain chronic diseases such as diabetes mellitus, hypertension, other cardiovascular diseases, chronic respiratory illnesses, chronic kidney disease, and liver conditions are more likely to be affected by COVID-19. And additionally, if these people actually get infected by COVID-19, they are at a much higher risk of severe COVID-19, critical COVID-19, and they are at a much higher risk. Their odds of death are much higher as compared to the general population. And this evidence basically points to the need that we need to continue actually managing non-communicable diseases appropriately, even in the midst of the COVID-19 pandemic. The unfortunate thing that happened, particularly in the first and second wave of COVID-19 in most parts of the world, Zimbabwe included, is that when essential services were cut, there was quite a drastic reduction in the services provided to the care and treatment of people with non-communicable diseases, which potentially might have led to suboptimal control of these non-communicable diseases. And obviously, suboptimal control of the disease would have placed the patients at odds of more or of worse outcomes with COVID-19. So the key point that we're taking there is that pre-existing non-communicable diseases worsen outcomes among patients with COVID-19, and patients with non-communicable diseases must be prioritized for prevention, including vaccination. So in any country that is implementing vaccination programs, I think people with non-communicable diseases must actually be targeted as key recipients for vaccination, and programs must be made in such a way that these people with non-communicable diseases are actually sort of prioritized and are put in place to ensure that even those who are living in marginalized or peripheral areas actually access vaccines when they have non-communicable diseases, because they are quite vulnerable to the effects of COVID-19. And patients with non-communicable diseases must continue getting their care and treatment services to optimize their disease and control. So this was my brief opening overview to the deliberations and discussions of the day. Thank you all very much for listening, and thank you to Professor Munodawafa and everybody who gave me the opportunity to make the presentation. Have a good afternoon.
Yeah, thank you very much, Dr. Grant. I always call him Dr. Grant. Hopefully one day we'll make big money and doing more research grants. Yes, thank you very much for this very detailed but very clear outline on the situation that we face. I know towards the end, in the intersection, he made an attempt to position certain key issues. And this, we have speakers who will be talking in detail around a number of the key issues that he has raised. But the main point here was to give us an understanding as a region, as a continent, why it is important to start thinking seriously, more than what we have been engaged in, with regards to non-communicable diseases and their contribution or the part or the role that they are playing in the COVID-19. We're looking at the number of deaths in the continent rising, the infections that are also coming up, but in terms of our case management, we now know the link that number of those that have succumbed to COVID-19 are very much linked to non-communicable diseases. With that, I want to go on. I don't see anything in the chat. I don't see any hand raised. So let me bring in a colleague who has invested much of his time looking at the non-communicable disease area to then continue from where Dr. Marianne Emma has left. So I want to call upon Dr. Prebo Barango to briefly introduce himself and take us through the whole issue around the issues around NCD, COVID, the comorbidity issues. Dr. Barango, you are around, right? Hello.
Yes, good afternoon, Prof. It's my
Good
pleasure.
afternoon, my brother, to see you.
Yes,
And
it's my pleasure
you
to see you as well.
Yourself. I've seen you as a young man, and I see you are graying now, which is good.
Thank you very much, Prof.
Okay, over to you.
Yes, thank you very much, Prof. Good afternoon, colleagues, distinguished colleagues, and thanks for organizing this very important and timely webinar. My name is Prebo Barango. Prebo, like everybody calls me Prebo, and I am the non-communicable disease focal person for the East and Southern African sub-region of WHO Afro. I live in Zimbabwe. So my interest is actually on NCDs and strengthening the health systems and developing policies and guidelines and strategies supporting member states in doing this to be able to combat or to be able to marshal out appropriate responses for NCDs. I'm trying to share my screen. One participant can share at a time. I think I'll need, it's telling me one participant. Okay, perfect.
Dr. Marianne, please unshare what that means.
Done.
Done, good.
So, you all can see my screen. Hello?
Yes, I can see.
Oh, perfect. So, I'm going to be talking about the NCD and comorbidities with the perspective of the African region. The previous distinguished speaker had talked about the epidemiology of COVID-19, and so I'm not going to dwell very much on that. But like we know, most countries globally are witnessing a third wave of COVID-19. And so this is showing all the WHO regions and including Africa to really show that both number of confirmed cases and number of deaths is on the increase. And specifically coding in on the African region, you can see the peaks of the different waves. We are currently on the third wave. And it also affects those that have been new cases that are confirmed as well as deaths in the region. The numbers are there, but that's really not my focus. Now, I'm going to be talking about specifically looking at comorbidities that are most associated with NCDs, and this with COVID-19. And these comorbidities vary. There are really a lot of them, which range from cancer to pregnancy to solid organ or blood stem transplant. And there are many conditions that predispose those that have it to getting a more, either to getting NCDs itself or to getting a more severe outcome from NCDs or unfavorable outcome from NCDs. So these are the comorbidities that we have. And so the task I'm going to be showing next will be to show that one, comorbidities are important, one, and two, that NCDs are actually a lot more much important in the African region. So, and then I attempt to tie both together to see how we can move forward. So looking at this data on the underlying conditions that I highlighted in my previous slide, you see that people with hypertension, obesity, chronic lung disease, diabetes, and cardiovascular diseases in terms of the age range, you can see the proportion of them that are hospitalized with COVID-19. Across all, mostly it's that for age, it's hypertension. For age and for hypertension and cardiovascular disease, it's really actually much more dependent on age. For obesity, it's also the younger age that are, of course, more likely to be obese. Now, specifically looking in terms of deaths, outcome from patients, you see that people with underlying outcomes for NCDs are much more likely to have to be admitted and have or both hospital admission, ICU admission, and to die than those without any underlying condition from NCDs. And this is the same we found in all the countries in the region, that people with underlying health conditions are more likely to have severe COVID-19 and to also have ICU, to be admitted in the ICU, and to also have adverse events, as in to die from the COVID-19 based on their underlying condition. So that is how important COVID-19 has been to NCDs. The previous speaker also had mentioned that most countries in Africa are undergoing epidemiological transition, and that's true. Most countries in the region have a double burden of communicable maternal and nutritional conditions with coexisting with non-communicable diseases. So what I'm trying to show here is actually from WHO's data, looking at the proportional mortality from all cause of death in all the countries in the African region. All the countries in the region are on the horizontal axis. For each of the country, there are 3 bars. The green bar representing total mortality from maternal, perinatal, and nutritional conditions. The blue bar representing mortality from injuries, and the red bar representing mortality from non-communicable diseases. So when you combine the 3, it actually should add up to 100. So here is showing that, highlighting that all countries in the region are battling with, a double burden of communicable and non-communicable. But the extent to which this is manifested in countries varies. So these small island developing states, for example, like Mauritius and Seychelles, have over 80 to 90% proportion of NCDs accounting for mortality. While a country like Central African Republic, its kind of slightly reversed, with about 60% being due to maternal and communicable diseases causes. But, like has been highlighted by the previous speaker as well, if we continue on the same trajectory that we are on now, by 2030, actually across all countries will be migrating towards the right side of this graph, having non-communicable diseases being responsible for the most mortality in the country. I've not mentioned morbidity here because it's of the challenges with morbidities, but we know morbidity, NCDs contribute significantly to morbidity. Now, the reason why this mortality is important is because now the risk factors for NCDs that has been mentioned before, which includes hypertension is an intermediate risk factor for several NCDs, including cardiovascular disease and diabetes. Actually also can complicate NCDs. We see that countries in Africa actually have the highest prevalence of raised blood pressure. It's higher. So all the countries are, as the previous slide on the horizontal axis. Sorry. All the countries are on the horizontal axis. And then the green bar that runs across all the countries is the global average. So you'll see that most countries in the region have a prevalence of high blood pressure among adults that is higher than the global average. So we have a huge proportion of hypertension, but that is not the story. The story here is that in most countries in the region, if not all, over 80% of people that have high blood pressure are either not aware or not on optimal treatment. And like I said, cardiovascular diseases, hypertension is a major risk factor for cardiovascular disease and diabetes. We have the same trend with obesity, and we have the same trend with physical inactivity. We are gradually becoming more sedentary in the region. So, trying to round up, COVID-19 has actually negatively impacted NCD outcomes in people through several pathways. Like I said, COVID-19, people with NCDs, one, higher susceptibility to COVID-19 infection and higher case fatality rates among people with NCDs. COVID-19 has resulted in NCDs being undiagnosed because of delays in diagnosis of NCDs due to the measures, closure of health facilities and transport and all those challenges, meaning that there's delay in diagnosis, resulting in also more advanced stages of the disease. Delay in treatment because of interruption in supply chain and treatment and things, and unprotected because of increase in behavioral risk. Most countries in the region now are going through lockdown, so at some phases, meaning that the risk factors are actually on the rise. You're less likely able to do some physical activity. You're more likely, people are more likely to abuse psychoactive substances, and there's also some violence going on. So that's how what COVID-19 has done. And these are just examples of how it's increased the burden. So increased infection risk for people with kidney failures who need treatment for dialysis, worsening cancer prognosis, deteriorating function among people with chronic respiratory disease because of interruptions in pulmonary rehabilitation. So what COVID has done, it has laid bare how we have failed to meet healthcare needs of people with NCDs in majority of countries, especially in the African region. There's disruption of health services. We're not really on track at achieving the UHC targets. And so we really need to, like the previous speaker had also said, we really need to have innovative ways of ensuring that we get people with NCDs, give them priority to access treatment and care. Thank you very much. I'll stop here.
Okay, thank you very much, Dr. Barango. Thank you. This is exactly where I wanted to get to. You have really lifted this presentation bar up from what the foundation that was set up by Dr. Grant. I think, colleagues, we are privileged to get some very concrete information that sometimes we don't always have at the tip of our fingers, because we're trying to reconcile these two areas and try to figure out what exactly is happening. But I think the presentation by Dr. Barango lays things out in the open, and I'm really excited. Let me check if we have questions in the chat, or if, yeah. I'm sure the question that we have may not be for you guys now, so let me not go back to that, but let me ask from the participants, do we have anyone who would like to raise their hand, would like to ask a question to the two presenters before we proceed? Do we have any burning question, things that you would want clarification, or you want to add, you want to express your view on an experience you have come across? If none, that is fine. The question that I was looking at is a question on vaccines, and I'm not sure. It says a patient after taking 2 doses of vaccine, meaning they've had the first dose and they've had the second dose, they still succumb to COVID. How is that? Dr. Grant, do you want to talk to that now, or you want to leave it for later? I think this is the only question we have. Hello? Dr. Grant, are you around? Okay, you may not be. Let me see. There is another question coming, and let me see if I can. Has there been any study in the African region so far on possible interruption of COVID-19 caused on access to care and treatment by people living with NCDs? Dr. Barango, I'm sure you can also check in your chat box, you'll see the same question. So a colleague from Bangladesh wants to know if there has been any studies in the African region on possible interruption of COVID-19 caused by access to care and treatment by individuals living with NCDs.
Yes, so last year, hello?
Yes, go ahead.
Yes, so last year, WHO actually did a survey of countries globally, including 42 countries from the African region out of the 47, to see the extent of disruption of services for NCDs. And the findings were actually quite revealing. It showed that the NCD services were disrupted. Mostly, the ones that were mostly disrupted were ones for palliative care, hypertension management, diabetes and diabetic complications management, asthma services, palliative care, urgent dental care, cancer treatment and cardiovascular disease. Those ones were the ones that were most disrupted. And on that basis, it formed one of the crux for one of the key reasons why, as part of the COVID response pillar, there's actually continuity of essential services now, and we're trying to support member states in ensuring that NCDs feature significantly in this. I'm happy to share the link for the pulse survey on the chat box for colleagues to see. Over.
Okay, that would be very good. That would be very helpful if you can do that. I want to thank the presenter, Dr. Barranco. Let's proceed now, and we have an opportunity to also look at what are some of the specific issues in the areas of policy and the strategy regarding the two issues or public health concerns we're talking about. That is the non-communicable disease and COVID. I would then want to invite my good colleague from Benin, from Parakou University. I'm sure he will introduce himself. Dr. David Weto. David, are you on?
Yes, please, dear Prof.
Okay, great. I'm sure we are also international, so you can always throw in a bit of the French for the colleagues to know how far wide we go on. Now I know that nobody owns this language anymore, so we are comfortable, but I know that we're all speaking in English for now. But please go ahead, give a short introduction of yourself, and again, my pleasure having you on the team.
Okay, thank you. I know Francis can really very well understand what I will be saying in French. So, Prebo, hi. And my greetings to everyone. It is my pleasure to be with you, sharing just some few slides. And I'm very excited by what I heard from colleagues, mainly from Grant and Prebo. It is very, very enlightening. So we built on that and tell you that actually the way to go will be definitely a promotion. And my name is David Hueto. I'm from Benin Republic, not Benin City in Prebo's country. So I'm a lecturer, actually, medical doctor and associate professor in health promotion, mainly in French-speaking countries in our region. So we are now developing a very good experience in this side, so that I think something is on the ground coming then. Let's just let me share my screen and let you see that building on what colleagues presented, I think it is now something, if I want to just look at it and say that, okay, as Prebo said, you know, the comorbidities most associated with COVID-19 patients actually in the region are hypertension, high blood pressure, as he said, and generally cardiovascular disease, diabetes, and asthma. And that came from a study WHO, you know, published last year. And it is, you can see what Prebo said is really in that track, actually. And when we see from examples in the region, countries leading the situation, actually, like South Africa, we see that 61% of COVID-19 patients in hospitals have hypertension, you see, and 52% have diabetes, and 45% of people aged 60 to 69 who died from COVID-19 also had hypertension, you see. And when we look at Kenya, around half of COVID-19 deaths occurred in people with non-communicable diseases. And as for DRC, 80%, 85% of all COVID-19 deaths occurred in people with NCDs. These are something very, very important, crucial to note. And actually, we know, I cut my presentation knowing that Prebo is there and he already said it, okay? NCDs actually require continuous treatment. And actually, it is not possible for our government in this region, while they are now taking care of this ongoing pandemic, so that health services for NCDs can be on a good way, continuing the services as usual. It is not possible. So we have disrupted services in every country in the region. For example, some studies coming from the region published by WHO in 41 countries showed that 22% of countries have only emergency inpatient care for chronic condition, you see, and for 37%, outpatient care is limited. And for 59%, hypertension management has been disrupted. For 56%, diabetic complications management has been disrupted also. So what is actually then the way to go? Because it is not possible actually for our health systems, the way they are with the platforms, let's say technical platforms, because we do have human resources, but it is a huge problem in the region when we come to the technical platform. And then the best to do actually, because we are not able actually to handle the situation of care to our NCD patients, I think we have now the opportunity to change the game in the health system, actually. So we can say that COVID-19 is a game changer to us to look at health another way, actually. So we need to empower individuals and communities so that they can address the root causes of NCDs, because it is not good at all, actually, to wait that these people, these our citizens, they come to the arena of NCDs before we start now saying or running after them to say we have to take care of them. But it is not actually, we can see it's not possible. Then we have to empower individuals and communities so that they can address the root causes already known of NCDs. You see this graph, very well known for all of you, that we have four huge domains of risk factors. And it is possible that we empower individuals and communities so that the health system actually putting health in every sector, what we call health in all policies, can manage to contribute to controlling these risk factors that are alcohol abuse, physical inactivity, smoking, and mainly in the region, unhealthy diets. It is critical actually that our health systems in this region focuses now on rather hospitals, but more empowering communities through every sectors. And you see, the way we should do it actually is that our health policies should be anchored in health promotion, Because with the purpose of maintaining and improving the health of population, health policy should be anchored in the principle of social justice. You know, what is social justice? Because the goal of social justice is to develop the ability of people to realize their potential in the society in which they live, so that when you give them that possibility to be themselves, doing what they have to do, they can take care of themselves. Because it generally refers to a set of institutions that enable people to lead fulfilling lives and be active contributors to their community. By doing so, you see, you are a carpenter. People can praise you that you are doing well. And then you will be bold. And knowing that, you will take care of yourself. And we know that the institutions that can help to do so are education, healthcare, the basic healthcare, and social security. And actually, you know, in our region, 80% of our population are illiterate, so that our health system have something to do with the education system. Don't sit down only at the hospital. You have to liaise with the education system so that our population be educated, you see? And I think it is very, very critical actually that these health policies we do need actually have some attention to human rights and equity, and based on evidence-informed policy and practice, and mainly, we know already, addressing the underlying determinant of NCDs, if you want. So just a recall on what is health equity. I don't want to bore you with this, but I wanted to say that it is strongly based on the principles of social justice and refer to the absence of disparities in controllable or remediable aspects of health. What I want to raise here is the notion of this notion or concept of social gradient. Because in fact, underpinning the equity notion is the concept of the social gradient that notes the poorest or of the poor throughout the world have the worst health. And within countries, the evidence shows also that in general, the lower an individual socioeconomic position, the worse they have. And you know, this is very, very critical, and you can make the connection with, you see, health equity and social justice. And these are concepts in our region that are not really very well known, actually. Because when we think health in this region, it is only hospitals, care, but it is, as study shows already, the health system or healthcare contributes to health for 10% when you have a good, a genuine platform. That is not the case in our region. So such an approach, you know, places actually health promotion, health protection, population health surveillance, and the prevention of death, disease, injury, and disability as the central tenets of all related initiatives. It is very critical that we change the game in our region then. It also means basing those initiatives on evidence of what works or shows promise of working. It is an unorganized, comprehensive, and multi-sectoral effort. Health cannot never be seen again as just for the health system only. No, because of this, because we are not specialists in education. So we need to liaise with these people to put health as a genuine multi-sectoral endeavor. And then health policy should then be clear with these notions and aim at addressing the social determinant of NCDs when it is the case, actually, especially in situations like COVID-19 pandemic, to improve health and save lives. So because we already, we knew that in our system, people know that, okay, yes, when we say NCDs, okay, if it is not care, then we go to prevention sites. But you know, prevention, if it is not an integrated one, you cannot succeed gaining results, you see, because you need people to change behavior, but you don't know that change the environment is the first thing to do, because when you change the gradient, it makes it easier to change behavior. So we do need to thank, in brackets, I want to say COVID-19, for us to rethink what is it health in our region. Thank you. I will stop there and let you ask questions, because I have more to say about how we can reorient our policies, health policies in the region, so that we can be able to handle situations, because COVID-19 is only one on within all these situations, emergency situations we do have in our region. And actually, we even don't know when will be the end of COVID-19, so that we need actually to change the game rapidly. Thank you very much again, and the floor is yours.
Thank you, David. Merci beaucoup. I appreciate very much your passion and the way you have positioned the key issues. Now, because we are raising the bar once again toward what needs to be done, we want to go beyond explaining what the problem is and being able to analyze it, being able to put things apart and put them together back again to the level that I think David has now taken us to discuss issues of policy and strategy, and anchoring this around the importance of multi-sectorality, the importance of health promotion, and the importance around ensuring that there is collective solidarity. No one is left behind, or no condition is left behind. I think this is very helpful. Any comments, quick questions? Let me check in the chat box if there is anything. Okay, not now, but do we have anyone who would like to raise their hand? Or if not, I think let's move on. Now that part of the strategy and the work that we have been doing in Africa, obviously, if anything, as we have seen with the area of vaccine science, vaccine development, vaccine access, and all that, we are not, we are not there yet. We are not leading, but there are things that we can do. And a colleague of mine talks to me about this every time. And he says, Professor Ariambua talks about this every time, that, look, we need to start looking at what we have rather than what we don't have, and see how we can use what we have. And I think that's a very strong argument. And I'm glad that David touched on this, but let's go to the next speaker. And again, let me be sort of apologetic, but not really apologetic, because we are very sensitive As we were working on this, we wanted to make sure that there is a gender balance, but it's not exactly the balance you're looking at. But we do have a colleague, we do have a female colleague who is with us, Aminata Kobi, who will introduce herself. You know, now it's important. Ladies want to do all that for themselves. So I'm not going to try and introduce her. She will do that, but she will talk in an area that I think Africa possesses a lot of opportunities. We own communication, we own communities, and I don't know if we are using them effectively. But let me give Aminata the chance to talk about this, and let's hear about risk communication, community engagement, addressing COVID-19 and the non-communicable diseases, the intersection. Thank you. Aminata, are you there? I can see you.
Thank you very much. Good afternoon from Brazzaville. My name is Aminata Grace Kobi. I'm from Sierra Leone, and I work with WHO as Risk Communication and Community Engagement Officer. I want to thank the previous speakers that have listed the major issues that has to do with NCD in the context of COVID. So I'll start by saying that risk communication refers to the real-time exchange of information, advice, opinions between experts and people facing a specific threat or threats to their lives and well-being. And in this case, people who are affected by NCDs have also to deal with COVID, where they are most at risk of having serious illness or from dying. And the purpose of risk communication is for people that are at risk to be able to take informed decisions to mitigate the effects of the threats, such as disease outbreaks and in this case also living with NCDs. Sorry, I'm having some problems with my slide. Let me just address this quickly. I'm still having, so I'm going to stop sharing, but I'll share with you the slides later. Sorry about that. So, we have risk communication is a very important task that is a core public health intervention in any response, either to a disease outbreak or to a public health issue. We have several components, but it is very important in the context we are talking about to be able to map people that are at risk based on specific risk factors. And in this case, it is very important for us to be able to identify people that need help based on their risk factors for NCDs, where they are, and to be able to develop specific packages, messages, and support for them. What is very key is for us to be able to get them involved, for them to understand, know what they are supposed to do, and for us to empower them to be able to take action for themselves. looking at what they should do to prevent getting very sick. How can we advocate for them for an enabling environment so that it's easier for them to make healthy choices, especially in the context of Africa, where it is difficult for people to make informed choices because of socioeconomic factors and because the enabling environment is challenging for them to take those actions. So we have various components which could be used: health education, social mobilization, engaging with those that are being affected and looking at their challenges, and both advocating for an enabling environment and also looking at the gaps and how they can make healthier choices, easier choices. We have behavioral change communication, rumor management, which is key, especially in this current outbreak. There are so many rumors that are preventing people from taking adequate measures to prevent themselves and to promote the health of their families, especially that has to do with using preventive measures, the use of masks, physical distancing, which is very difficult if you are poor and you have to use public transport. So working with other sectors is really key in this. Monitoring rumors and addressing those rumors, and advocacy for change of policy that will help people living with NCDs to make those choices. So we need to help people living with, work with people living with NCDs to improve their decision making, decisions on what actions they should take, and promoting the use of vaccines, facilitate adaptation of recommended behaviors for communities and individuals, and contribute to the prevention, control, and response dealing with both COVID and NCDs. We need to have stakeholders engagement, especially with policymakers, Ministry of Health, and people themselves that are living with NCDs. We need to mobilize the media as key partners to understand their situation and for them to be really targeted with specific messages. We need to work with workplaces, in the communities, in the villages, in the markets, for them to understand the needs of people that are living with NCDs. Taking into consideration the 5 key principles of risk communication, which is announcing early and being transparent to the public and those that are being affected, creating and maintaining trust, listening to, understanding, and respecting public concerns, plan with and them, and to ensure equity even as we're implementing. To conclude, I will just say that building and maintaining trust is the most important function of effective communication and risk communication. Risk communication in NCDs should include participation of the public, early and regular communication, and engagement with those that are affected. Is a very important public health tool to managing risks. Thank you very much. I'm sorry that I have not been able to present my slides. Over to you, Mr. Chair.
Thank you very much, Aminata. Thank you, and we apologize. I know how this technology sometimes also gets in between, but we're happy that you touched on some very key issues that are important for this area of risk communication, community engagement. As I said, this is one area that the African region will not have to go outside the continent to look for support. We do have a wealth of risk communication, community engagement, all the way from the way our history, our culture, all societies we have been communicating at different levels and on different issues. I also want to just highlight that I think the last part of your presentation around building trust is very, very key. What we are seeing in COVID-19 in terms of the mortality. There is a recording that was shared here in Zimbabwe from one of our leading medical doctors on the front line, saying that, as we know that the cases, the number of deaths are rising, while the number of new cases may be coming down, but the deaths are rising. And basically what he was observing is that people are coming to the hospital too late. And if you can unpack that, then one begins to understand why it is important for risk communication, community engagement. Why is it that people come for the services that we know? Why do they come in late? We're talking of vaccine hesitance. Why is it that people have been sitting on the fence for very long, and we are beginning to see a surge because of some of the pressure that is coming from different circles within government, where you're hearing that, you know, you may lose access to certain services because you have not been vaccinated. You may not be able to ride public transport because you have not been vaccinated. All these things, but why is it that people are delaying? And I think this is where the communication, risk communication, community engagement comes in. And it's not simple, it's not easy to close the knowledge gap. It is not easy. That gap we see is not very easy to close. It may look very simple from a distance, but once you get inside communities, you'll then notice it's not something easy. So I want to thank you very much, Aminata, for the presentation, and please share your presentation. Do we have any quick question? Let me check what is on the chat box. Thank you very much, Aminata, for the presentation. My inquiry is on how best, so this is a question for you, Aminata. How best can proactive health promotion, especially RCCE, be prioritized, considering that COVID-19 response took too long to focus on RCCE? Social media outpaced authentic information. Interventions like vaccinations are facing much resistance. Did you get, I'm sure you can also get to the chat and look at that question, Aminata. The second question is, serious information and misinformation on vaccines is coming from some religious leaders who are discrediting vaccines to the detriment of their followers. Seems age, class, education is secondary and religious affiliation takes over. What can government do? So these are two questions. How to handle disinformation and misinformation? That was another question again, Aminata. Has there been, okay, so those questions for you, Aminata, can you quickly share your thoughts? And the other three colleagues, if you're thinking of any, or, you know, even the fourth colleague who hasn't presented, Dr. Musoka, if you have any comments, but let's ask Aminata to respond. Aminata, can you go ahead?
Oh, sorry, I already started, but my mic was
You can even
mute.
take your video off because your streaming is, yes. And I was saying you can even take off your video because sometimes these systems get really.
Yes,
go ahead.
Thank you very much for the question. Risk communication has been very critical in this outbreak, and we have misinformation that has been really affecting the public. So what can communities do and what can governments do? Governments need to be providing accurate, regular information to the public, and there's a need to build trust. Building trust is critical. Government should be seen to be doing what they are saying. Remember that the public is very observant and they see what the governments do, and they know if they are really sincere about preventing COVID or not. So it is key for government to be sincere and to say what they know, giving reliable information to the public. What they don't know, they can also say, we don't have adequate information on this. When we do have it, we'll explain to you, we'll discuss with you. This is very key. For misinformation at all government levels, at all decentralized levels, we need to be listening to what the public are saying, understanding the gaps, and helping those affected to be able to address the gaps that they have. Any country where you find out that the population does not trust the government, you realize that they have big challenges with responding to the outbreak. Mixed communication, community engagement, health education, health promotion is key even before the outbreak. How do we work with communities? How do we set up our systems? Remember, from the days of primary health care, mixed communication has been core, or health promotion has been core, and is at the center of primary health care. We need to maintain this and maintain our relationship, understand what are the gaps, what are the challenges with communities, meeting their needed needs and explaining to them. It is very important to work with influencers, such as religious leaders, and each community has a group of people that are very influential to them. A influencer in one community might be very different from an influencer in another community. So there needs to be understanding. We need to be doing a lot of research to understand the public, to understand the communities we are working in, and using that information to plan programs and also to develop messages to address the gaps that we find in those communities. It's a difficult aspect to do, but we need to be committed. And in most countries, the challenge is that mixed communication is expensive and governments don't invest a lot into engaging communities, being in touch with communities, and addressing the needs of communities. I will stop there so far. I see someone wants to ask more questions. Over, Mr. Chair.
Okay, all right. Thank you very much, Aminata. Do we have any of the colleagues who wants to jump in, say something, or?
Someone's hand is up.
Can I come in?
Oh,
Yeah.
someone, their hand up, sorry. I didn't see that. Okay, Techno Spark, please go ahead. Please go ahead. Please go ahead, Techno. Are they there, or it was an accident? Maybe.
I think it's an accident. The hand is now
Okay,
down.
no, let's move on then. Thank you very much once again. And colleagues, now for our final presenter, the context is that the African region is not an island on its own. We are part of the global village. And there are things that do happen, and we are not on our own. But at the same time, it is important that we take our place in the global village. And this is one area that I think COVID-19 has demonstrated the importance and the need for collective solidarity. While each and every one of us play their part, we also need to get the support and the working with others, that multi-sectoral issues that David Weto raised, but this is now at the global stage. I have with me a colleague whom I was with in the trenches during the time of the Ebola outbreak in Liberia. And I will let him also introduce himself and maybe share one or two things. His name is Dr. Musoka Fala from Liberia. He will give us the global context or the global response and how we fit as a continent in Africa, as a continent, how do we fit in the bigger picture and what are the issues surrounding NCDs and COVID-19. Please, my good brother, I'm
Yes,
sure you are
hello.
in beautiful Liberia. I miss Liberia.
I know,
Okay, over to
yeah.
you, Musoka. Please introduce yourself and take it from there.
Okay, Prof. Thank you so much, Prof, for the opportunity. I too will send you my slide later. I'm Musoka Fala. I'm an immunologist by training and also have an MPH in infectious disease epi. Teacher at the University of Liberia. I'm a visiting faculty at the Harvard School of Medicine and recently with Boston University. Prof. Davison and I go a long way from helping with building, as you know, the Prof. Davison, one of the pioneers in health promotion, community engagement, working in the trenches. And we've come together again over the last several months trying to advocate as a continent for vaccine access and equity through our open advocacy. And also we've been writing articles to advocate for Africa, looking at some of these issues. So again, it's an honor working with him. I will speak briefly on the global response. I'm going to go through a time period, how this concept of the global response to NCDs and where are we currently in the continent and then Africa, the entire world, the global community in Africa. The best way to look at this is that the concept now is that what we are seeing today that is being amplified by COVID-19 is because of the pre-COVID inequalities and treatment and access to NCDs. They've been neglected in many budgets. To some extent, they almost like basic inequalities. And so let's begin at the level of the UN. So WHO UNDP sometime around March and April met with the UN, formed what they call the UN Interagency Task Force on the prevention of NCD and COVID-19. Basically, it started with the wake-up call that basically the pre-existing conditions we've had, our inability to provide adequate services, our inability to provide access to care, to really document the number of people suffering from NCDs has just been further amplified by the COVID-19, by the fact that of the 3.4 million deaths that we had so far, majority of them are people suffering from the NCDs. And so basically the whole thought started at WHO, the UN system, the UN Secretary General to say we need to come back together and rethink because the numbers are facing us every day. That like our previous colleagues have said, the fact that you have one of the NCDs increases the risks of the disease, the severity of the disease, and the higher rates of dying. As we all do know that the study that was done in Lancet that showed from 10 countries in Africa show that 50% of our people that go to treatment unit in Africa will die. And so basically that framework was started to look at how do we develop the opportunity that, I hate to say it is an opportunity, but in the midst of this dark cloud, how do we build the system that will integrate NCD as a part of the response? I will go back later to the survey that was done in May, but clearly it was demonstrated that in most countries—
excuse me. Fala, are you showing any slide? Are you showing any slide?
No, I'm not showing slide now. No, sir.
Okay, no problem. Thank you.
Okay. It was shown that very few countries had NCD as part of their response plan. And so the UN task force on NCD came together and said there's a need to integrate NCD as part of the response plan. Go forward to early April, when the WHO working group was created on within the UN Secretary General Office to look at NCDs specifically. And so the technical working group was established to look at the challenges created and to find some solutions. Basically, the framework look at how do we first of all find potential pharmaceutical products for those suffering from NCD that can be integrated within the treatment, the therapeutics. The second issue was, what are the major framework that this task force can develop to mainstream NCD? Some of those, the local issue of advocacy, governance, surveillance, all of these had been ignored. And so the technical working group that the issue created decided to bring all of these together, the advocacy piece, the surveillance piece, identification of drugs, and the monitoring piece. And so what the technical working group did was to create indicator and a monitoring framework to track these. And raising this key point because they will culminate into the survey that was done in May of 2020 to look at basically where do we stand with NCD in terms of COVID-19. After the framework was established and the technical working group was developed, the conceptual framework was developed. So this is WHO and the UN task force. And the conceptual framework was, how do we reinforce a resilient health system? How do we ensure that it is integrated within the response? Secondly, how do we ensure post-COVID-19, we are able to ensure that NCD becomes an integral part of the health system? All of these, the technical working group, the interagency group, that culminated into the development of the rapid assessment that was done in May by WHO that my previous colleagues spoke about. There were very interesting findings that I want to speak to about that global response with respect to the survey. The survey covered a total of 163 countries that responded. Some of the key findings they show was, one, that the NCD services were completely disrupted by COVID-19. Over 2/3 of the NCD services were disrupted. In terms of NCD staff at the various ministries of health, their commitment to support the COVID-19 response, only 13%. They also show that greater than 50% of all cases of cancer diagnosis were compromised by means of the COVID-19. Over 28 million surgeries that became elective surgery that were cancer, majority of them had to do with NCDs. So basically the survey clearly showed that the pre-existing inequality, limited support in budget to NCD were further amplified by the COVID-19, by the fact that only very few countries had a budget line for NCD support. Very few countries were committing NCD as a part of the COVID response plan. Key finding that happened was the fact that most of these were further amplified among the low middle income countries like Africa. Most of our services were disrupted, and even our intervention, some of the intervention we set up, such as the lockdown. The lockdown had unintended consequences on NCD. While I say we're protecting the spread of the disease, but by means of the lockdown, we then deprived those NCD to access care because there were limitations in transportation. And then the fact that we had all cases that were severe acute inpatient cases had to be reduced to elective surgeries. And so the whole findings from the WHO survey that was done in May as a way of determining how to intervene with respect to NCD and COVID-19 clearly show that basically services to this vulnerable population got disrupted. They are the most at risk group to die, to develop severe diseases, but some of our popular intervention compromise their ability to access healthcare. And so one of the key findings for which WHO is helping to respond were twofold. One was that most of the country, most especially in Africa, introduced some form of triaging. That most of the countries that have pre-existing ability to triage disease and concentrate on most of the inpatient severe NCDs and COVID, or those that didn't have NCD was introduced. And so one of the global response WHO is now undertaking is basically to develop a working tools for triaging in the midst of the COVID-19 that will get cascaded down to the health facility so that we can triage and prioritize those NCDs that needs urgent care. The next thing that was introduced as a result of our result of the COVID response was the issue of telemedicine. Telemedicine was really shown to be an active part of the response. However, what they clearly showed in our work was the fact that because of our lack of adequate technology to support telemedicine, it was not as exactly higher as developed country. But what has been clearly shown that in the midst of the COVID pandemic, the way that support can be provided for those with NCD is telemedicine, anywhere from a simple phone call to some of the apps. And so we show that between March, April, and May, the conceptual framework was developed, the survey was done, and clearly it shows that there was disruption of service. What is the way forward? After the global community has organized and recognized the issue of the risks and even our intervention and NCDs. One of the interventions that has been shown has been the issue of the COVAX platform. In September of 2020, the DG of WHO spoke. He clearly spoke for the support of the COVAX platform that will include 20% of the vaccines for all countries where countries cannot afford. 20% of the vaccine for countries cannot afford included two major groups, the frontline healthcare workers and those that are at higher risk, those with NCDs and then the elderly. And so that has been the push towards that. It is sad to know that despite the fact that we have made this clear-cut issue that those with NCD are higher risk of the disease and dying, COVID has not been as successful as possible. But from a global perspective, this has been a key point of advocacy that these people are at risk, that some of the intervention we created, the public health measures, while they may be of themselves good, but it deprive them from accessing services. At the level of the Africa CDC, the Saving Lives initiative that has been started by Africa CDC in collaboration with the MasterCard Foundation to acquire about 50 to 60 million doses of vaccines. Those are also going to target the NCDs. Those with NCDs going to be the first group, the highly vulnerable population. So basically from the point of view is that our advocacy needs to be pushed forward. The global community has agreed within the framework that NCD form a part of the response, the COVID-19 response. That has gone beyond the point of just a framework to a technical working group, and now the issue of the survey, and now putting in advocacy that these people need to access the vaccines. And this is, in summary, the global response at this stage, where the great advocacy is that in terms of those at risk, the most vulnerable population, those with NCD needs to have the vaccines as soon as possible, because they are the most likely group to access the vaccine, to contact the disease and to die. We do know that there is a challenge. The challenge is that the infodemics and the rumor is affecting this global response. So from the supply side, there are inadequate vaccines, even though the goodwill is there, but from the demand side, we have vaccine hesitancy. How do we manage the two? Going to be a great project. The good thing is that the Africa CDC, in conclusion, have launched a call for proposal to look at the issue of hesitancy, look at the issue of effectiveness of vaccines across the far region of Africa. And so normal NGOs will get involved to roll out this study across the far region of Africa, look at the effect of vaccine effectiveness and vaccine hesitancy, and how they will affect the overall vaccine literacy. I think it's going to run for 2 to 3 years. It's going to be around 2 million per partner per consortium. So a combination of WHO intervention to look at triaging, telemedicine, and the fact that Africa CDC is looking at it from both ends, acquiring vaccine to target the vulnerable population and supporting indigenous national African NGOs to conduct these studies that will enhance vaccine acceptance and that will affect all vaccine literacy in these countries. Thank you very much. I probably will stop now.
Thank you very much, Dr. Musoka Fala. Thank you so much. This is very enlightening. I think it works very well in terms of the way the program was envisaged, setting up the foundation with the strong epidemiology, moving into looking at the intersection of NCD COVID-19 and with a strong understanding of how we have come to where we are today in terms of NCDs being a major threat to COVID-19 infections. And getting to hear the policy and the strategy issues that we need to focus on. And the presentation by Aminata on risk communication, community engagement, an area that I think Africa has championed over the years, from time immemorial, but seem not to be serving us well now when we need it the most. And the global response or the global picture that you have now given to us, Dr. Fala, I think this is really very, very important. We need to have this information. A number of us think we are technocrats, we are practitioners, but we are affected in one way or another by the decisions that are taken very far from where we are. And I think it's good to get the context, to get to know. Let me check what's on the chat box. Appears there could be a number of things that are being looked at. Looking forward to accessing the presentation. Fine, yes, we will do that. Yes. We do agree that effective vaccination of high-risk NCD patients is the need of the hour. Thank you. Someone has their mic on, please, can you mute? There's some background noise. So, in fact, we have just good comments, not questions. Let me invite, are there any questions from the participants on the last presentation, if any? So we don't have, but let me, I just want, Dr. Fala, can you maybe even share this through, you can share this and send it to me, or if you have it with you, could you just find a way to post it so that others also benefit? I'm interested in the Africa CDC resources that are available. One of the big challenges that we face, we have a lot of good people out here in terms of competencies and skills who would like to go after some of these resources. And I am aware that oftentimes we come short because we just don't have the right combinations at times. At times we just cannot meet the deadline because there is just too many things being asked of us to provide and they don't come out. I mean, we still have offices in our systems where if you send something as a request or a signature, it will come 2 months after the thing is gone. But would you be in a position to tell us about the Africa CDC funding? I know there is one that is ending today, the Africa CDC MasterCard funding. It's a huge amount of money, and there is funding for every aspect. I think the 6 pillars of the health system are being funded. But when we were in the pre-qualification webinar, and there was a strong request by many African institutions to extend the deadline from, I think, around the 6th of July. And everybody was asking that if you could just extend it, but I think the extension never took was never granted. But I would want to hear more about the funding opportunities. And thank you also for finding time to stay on the global arena and getting our voices heard in such meetings. I think this is an important aspect. For those of you who are interested in what's happening at the global level, Professor Dr. Musoka Fala is one such public health activist. And I can take the opportunity to tell you that in 2015, or is it 2016, don't let me give you the wrong quote. Professor Musoka Fala was the Man of the Year for the Time magazine. If you remember the Time magazine Man of the Year during the Ebola, he won the Man of the Year award that year for Time magazine, recognizing an individual who has contributed immensely to Ebola. Thank you very much.
Yeah, thank you, Prof. I'm honored. I think it's $1.3 billion from the MasterCard Foundation that has come to the Africa CDC. And I think this I know for sure, they are trying to procure around 60 million doses of the vaccines. That will cover around 5% of the African population that is on the supply side. And so there's just this grant that is expiring today. Yes. And the way the structure it was actually, I think it was great because it was meant to be non-governmental organizations, and it meant to be led by indigenous national Africans. It had to be led by Africans themselves, and they could come as single country, or they could come together as a consortium of country, either from say West Africa, Southern Africa, or East Africa. I'm leading such a consortium in West Africa. Well, just like as you are, the challenge is that the timing today is the deadline, and we've been working all night to get it. I hope they can listen and understand it. But that's one of the stream of funding that Africa CDC has. I know within that MasterCard Foundation, they will start to lay the pillow for vaccine manufacture. I can send you the saving lives concept that they have developed for the MasterCard Foundation. I can email it to you, and then you can circulate to other people. I can send that right after the meeting to you. It has around 6 pillow: vaccine manufacture, vaccine deployment, working on hesitancy, and vaccine procurement. Thank you.
Okay, thank you very much. Thank you very much, my brother. I appreciate all that. And colleagues, the email for those who would like to receive a certificate from the World NCD Federation for participating in this webinar, the email has been posted in the chat group. I would urge you to request one because it's just something good to have. I even have one for crossing the equator in one airline, which is, they told us now you have crossed the equator, and they went around and gave us a little certificate. But this is important because we rarely get to convene such a meeting. And I want to think that this is the beginning of much more bigger things to come. Collectively, we need to come together. You hear the amount that Dr. Musoka Fala is talking about with Africa CDC. Very soon, we will reach a point where we're no longer saying, I don't have money. It's just, I don't have time to do things that are required, because putting together these grants requires time. So the money is coming, money is available. Yes, I want to give our panelists an opportunity to just say in one statement, what is the take-home message that you want to leave us with? I want to start, let's now do it in reverse order and start off with Dr. Musoka Fala. What is the one word or statement you would like our participants and the World NCD Federation to take with them?
We do know that vaccines reduce severity of the disease and death And we do know those with NCD are at a higher risk for severity and death. So as a federation, we need to advocate to target these people for vaccination and include them in the COVID response. Thank you.
Thank you. Thank you. Aminata.
Yes, for risk communication, we have to build trust. We need to involve people in decisions with regards to their health, and we need to understand the gaps that prevent them from taking health decisions. Over.
Thank you very much. Dr. Weto.
Yes, please. Mine is to say that actually there is no place in our hospitals. Our ICU are very full now. So I think we have to take the opportunity, the message COVID-19 is giving us, which is to know that health is elsewhere than hospitals, so that we need to empower our people so that they can have the healthier choice, the better choice, so that we overcome not only COVID-19, but the other diseases and improve health of our population. Thank you.
Thank you. Dr. Barango.
Yes, thank you very much. I want to agree with David. COVID-19 has actually laid bare the years of underinvestments in NCDs to be able to, and it also gives an opportunity for us to build back better. It has shown that healthcare, like David mentioned, it's not just about hospitals, and healthcare goes beyond that. WHO's definition of health goes beyond just hospitals, that we need to really invest in ensuring that access to prevention, access to treatment and rehabilitation forms a core part of our policy making and resource mobilization and allocation. While we are doing well with the predominant cause of mortality of infections and maternal and child health issues, NCDs is going to be here with us for a long time. So we really need to take a look at how we tackle NCDs. NCDs is behavior change and health promotion is a key part of NCDs. So we really need to have a holistic view about NCDs, both with COVID and with other pandemics that we are sure going to witness in future. Thank you very much.
Thank you very much. And Dr. Grant, are you around? Okay, I think he sent me a message. From me, colleagues, let me say that I really would want us to begin to find ways of coming together and projecting our ideas, our thoughts, our challenges and opportunities. So this is something that I passionately believe in now, that for Africa to move and to move a step further, we need to build a technical base. So now that I retired, so this is where I'm coming from, I realized that I retired, meaning I'm someone who is not important. But one of the things I have been reminded so many times, and thanks to all those who have done that to me, is that we become very resourceful, especially to those that we have left the baton, or those who would want to carry the baton. But at the same time, unless we have ways of convening and exchanging like this webinar and other Zoom meetings that we now do because of COVID, we may not be able to make any contributions, and we will not be able to grow the technical base that we need as Africa. Yes, I'm not saying you pull the ladder after you climb. I'm not suggesting that anybody should not go abroad. But honestly, we have opportunities now here in Africa to save and support each other. So my take-home message is that let's see how best we can grow the African base of technical expertise. I think this is very, very important. And I want to thank the World NCD Federation for being able to do that. I see Rachel is, so we want to thank the World NCD Federation for bringing us together as a continent and bringing expertise from the different countries. And I hope we continue to do this. We find our own resources within country, within the regions, within ECOWAS, within SADC, within East and Southern Africa. Within Africa CDC itself, we should be able to work together. That is my take-home message. I want to invite Dr. Taku. Are you still around? Hello, is Dr. Taku still around? Ria, do you know?
Dr. Davison, I guess he's not around right now.
Oh, okay, so Ria, on you standing in for Dr. Taku, I think you could just also thank our audience and we officially close the meeting, unless there is something that I have not picked from the colleagues. Otherwise, I think there's been very good messages. Everybody's grateful, thankful, and that's very nice. So Ria, can you just officially close for us then?
Thank you so much, Dr. Davison, and I would like to thank all the speakers for today for such an enlightening and enriching talks and depth knowledge of what is going on in Africa and the burden of NCDs and COVID and their interconnectedness. And I'm sure it was very much beneficial for all our participants. And also, since this whole thing would be available, the whole webinar would be available on Facebook and YouTube handles of the official World NCD Federation sites. So I'm sure a lot of people would be seeing from there as well. I would like to thank everybody for attending this and being present today and with us for this webinar, and hoping and looking forward towards such more learning experiences with all the great faculty. Thanks a lot, and thank you on behalf of World NCD Federation.
Thank you very much. And one last thing, Ria, are we going to be able to get the recording of these proceedings, right?
Yes, it is being recorded. It is right now currently live on Facebook as well, on the World NCD Federation official page. So, and I will share the YouTube link as well.
Okay, thank you very much. Thank you, colleagues. I think we call it a day, wherever you are. Those who are, it's getting late in the evening in the East and late in the afternoon, and please take care. Let's stay safe. COVID is real. Thank you.
Thank you, Prof.
Thank you,
It
Prof.
was really good.